me the background that you have?
I'll
No,
send it for
you
you.
can't. مش هيك, not like this, right? You cannot.
Yes.
Okay, خلاص. لكن I will راح أخلي الكاميرا. It's okay.
Okay. It's exactly 9 p.m. We are on the last Wednesday of this month. As we announced it before, the last Wednesday of every month, we will have a presentation or event endorsed by the PARSGO Association about an evidence-based case series we will discuss with you under the name of Decisions Before Incisions. And today we have the new president of the PARSGO, Dr. Sarah Nasser. I am proud to introduce her and to tell her that Alf Mabruk for the presidency. And she can present the Dr. Basel to the well-known Dr. Basel to our attendees.
Thank you very much, Dr. Khalid. It is a pleasure to be here and to see again our family and our community growing. Yourself and Dr. Basel need no introduction at all. Thank you very much. I will start by introducing myself. My name is Sarah Nasser. I'm the acting president of the Pan-Arabian Research Society for Gynaecology. And today I'm in the presence of Dr. Khalid and Dr. Basel, two very key players within the growth of the PARSGO Society, gynaecology surgeons who have really made a huge impact in the region for women with gynecological cancer through collaborative research projects within PARSGO and also educational projects. And looking at what we've achieved, we are now introducing a new educational series within PARSGO. It is called, as Dr. Khalid mentioned, Decisions Before Incisions. And this was an excellent idea. This educational series will be led by Dr. Basel, who really needs no introduction. He's PARSGO Steering Committee member and ESGO Council member. And this educational series is in collaboration with the Egyptian Gynaecological Oncology Society. Is really our sister society since the very beginning. So I'm very pleased to introduce this new educational series, Decisions Before Incisions, on the last Wednesday of every month as part of this amazing collaboration. And I will now give the word to Dr. Basel to tell you about the inception of this idea and to start by presenting the first case. Dr. Basel will present the case, and we are really looking forward to making this educational series grow and inviting more and more of you to present and discuss these cases. Thank you very much. And Dr. Basel, over to you.
Yeah, thank you, Sarah, for the very nice introduction. Thank you, Dr. Khalid, for moderating and taking care of all of this. And again, I'd like to congratulate the PARSGO first for promotion of Dr. Jalid, the ex-PARSGO president, to be the ESGO president. Now we are the president of European Society of Gynaecology. Is Jalid Suhuli, one of the founders with Sarah of PARSGO. And now Sarah is the acting president of PARSGO. Congratulations, Sarah, really well deserved. You have done so much for the society, and it is very well deserved and very well understood, and everyone is so happy with that. So to go without delay, this is a new idea of series that we are going to share with you. I hope it will be nice for you. I'm waiting for your feedbacks. I'm waiting for you because this is a new adventure. So I'm going to start without delay now. I hope my screen is clear, Dr. Khalid. Khalid, Sarah, is it clear?
Yes,
it is very clear.
Yes, and now the slides are moving, right? Not like
Yes,
The
yes.
slides are moving, yes.
So again, I like so much doing the PARSGO, which to remind you, it is the Pan-Arabian Research Society. So we need to go down to the ground, to what really happens in our region, to the problems. Not to say we are the best, we are speaking about very advanced, but really I'm going from here to there and I see many problems. So I'm going to be very basic today. So this is a real case presentation. Every word in this case is real, okay? This is a 53 years old single female, of course, who was complaining of pain and pressure symptoms, a classic straightforward ovarian cancer case with large pelvic mass and marked elevated CA125 with non-significant anything in the past medical or surgical history, and her family history, the grandmother who had colon cancer. So again, a straightforward case had the initial diagnostic workup where her ultrasound revealed moderate ascites, number one, free fluid in the pelvis and peritoneal cavity, a large adnexial complex cyst measuring 12 by 7 centimeter, which is ovarian origin likely, multiloculated, so it is ORADS 5, seen anterior to the uterus and close abutting the uterus. So again, a straightforward case. The next step is to do CA125, which was 1,105, which is markedly elevated. And the imaging was done, it revealed moderate free fluid, and in the midline of the pelvis, there is a multiloculated, predominantly hyperdense mass, thick, irregular internal septations, looks like a malignant mass, 14 by 12 by 8 centimeter, with significant mass effect over the collapsed rectum, and no para-aortic lymphadenopathy and no peritoneal nodule seen. That was in November and December 2024. So the oncologist asked for her a PET CT, which is usually asked for. And again, it revealed a large heterogeneous mass, the same with SUV of 18.2. So now we are facing a real malignant mass, 14.3 by 18.6. Okay, and intense intrauterine lesion, which was SUV 27. So suspected for neoplastic lesion inside the uterus. That was new in the PET CT. But the PET CT revealed that we had patchy FDG activity over the adnexia, pelvic peritoneal reflection, SUV 6, moderate to marked pelvic abdominal ascites of low-grade activity, mesenteric omental fat stranding, and pelvic peritoneal thickening, suggesting peritoneal metastasis with malignant ascites, and rather that there was no lymphadenopathy and nothing else rather than that. A histopathology was done, cytology from the ascites. The ascitic fluid in December revealed no malignant cell. However, the tissue biopsy from the omental disease was metastatic adenocarcinoma, and the IHC was consistent with mucinous or endometrioid adenocarcinoma, which goes with the intrauterine lesion, which is SUV 25. So it was metastatic adenocarcinoma abdominopelvic, mostly of ovarian or endometrial neoplastic lesion. So the tumor board was in January 2025, and it recommends tumor board is the multidisciplinary team, of course. The multidisciplinary team recommended neoadjuvant chemotherapy. There is peritoneal disease, there is omental stranding. The biopsy from the omental was positive with moderate ascites, so the recommendation was high CA 125. They recommended neoadjuvant chemotherapy followed by debulking surgery if response is achieved. She received 2 cycles of neoadjuvant carbopaclitaxel that was complicated with grade 3 anemia requiring blood transfusion and DVT in the left lower limb, and she was kept on Clexane. The CA 125 was 1,105 and then raised in January to be 1,500 and then raised on February to be 1,956. So it was rising laboratory markers, and the imaging was done in January, I think. It was significantly regressed ascites. No, in June 2025, significantly regressed ascites. The mass was enlarging 19 by 9 by 17 centimeter, regressed subcutaneous edema, decreased caliber of the left femoral vein due to this thrombus, and the impression it was a regressive disease. And the marker decreased now to be 553 units from 1,000 to 500, but still high. So they did a CT, and the CT increased the size of the mass. The mass was increasing in size, while other abdominal and pelvic finding remain stable disease. So the surgeons then said that there is no role for debulking surgery because the disease is stable, the marker is still high, the mass is increasing in size. So she continued on systemic therapy, and then she shifted to liposomal doxorubicin with bevacizumab, and the CA 125 was from 552 to 512. It was in the same area. So they considered it as a platinum-resistant disease. They asked for folate receptor alpha. You know, now we have mirvetuximab, which is a new evolving drug in platinum-resistant setting. If she is folate receptor positive, she can have the mirva or the mirvetuximab, but she was folate receptor alpha negative, so she is not candidate to have the mirvetuximab. This is a mass. This is a very large mass. A photo of this, of the mass, and the regressed ascites. Now you can see ascites in the field. So she was represented as the National Tumor Board for discussion and the proposed plan. When you propose a case in our National Tumor Board, you put the proposed plan of management, And the proposed plan of management was this is a platinum-resistant ovarian cancer. The mass is not responding. It is the marker is not so much responding, and still the abdominal disease is stable. So and she has taxol-carb, she has bevacizumab, she has doxorubicin liposomal, and so either going on another line or palliative care, and that was the proposed plan then. So now, Sarah and Khalid, I'd like to go back to our case. Okay, from the start. I asked them in the tumor board, why palliative care? Just wait, we need to go back, a flashback, and discuss everything in detail. First of all, what do you think, Sarah, about the PET CT that was done for that case? This is a PET CT. You see the PET CT that shows an ovarian mass, uterine mass, and peritoneal metastasis with malignant ascites. And I'd like to open the floor as well for our attendees.
Thank you very much, Basel, for this very interesting case presentation, particularly the progression of the case and the various treatment checkpoints, as we would say. So this was actually the first point that I wanted to discuss. So in terms of diagnostics, she came in with ascites and a pelvic mass with elevated tumor marker CA125, 53-year-old lady. We know that in terms of diagnostics in a primary disease setting, ultrasound biomarkers and CT scan can give us a complete picture of the disease situation. So normally we would not ask for a PET CT in these cases unless it is a very particular situation. The evidence and the guidelines also recommend a PET CT is not necessary for the diagnosis in a primary setting, as a CT scan is quite sensitive for lymph node disease and extra-abdominal metastases. So PET CTs really only in very select situations, and most of the time not in a primary setting, but rather maybe in a multiple recurrent setting or in an unusual or atypical presentation of the disease. So from my point of view, in this case, it was unnecessary to ask for a PET CT. You mentioned that this seems to be a standard procedure that you'll be doing. So I'd be interested to hear the reasons behind that and what your experience is with that. But it would not normally be a diagnostic imaging tool that we would ask at this point in time, specifically with what the CT scan and the ultrasound had already shown. And indeed, it did not actually give us any additional information, in my opinion, the result that you've shared with us.
Thank you, Sarah, so much. This is perfectly the answer I wanted to hear, because as long as we did the ultrasound, the CT, that case was for upfront surgery, but doing the PET CT showed those pelvic peritoneal disease and omental stranding, and so the decision was shifted to neoadjuvant chemotherapy. PET CT is not standard of care in diagnosis of ovarian cancer. And this is the ESGO guidelines that would be published soon. This is ESGO 2026. And as you can see, that ultrasound and CT are the primary diagnostic plan. And then whole body diffusion weighted MRI for the peritoneal disease, which is much more sensitive for the peritoneal disease rather than the CT. And PET CT should be reserved for specific indications. And then you can read, as Sarah said, specific indication when you have something equivocal. So that is the European guidelines. What about a region with limited resources, with more than 50% of the region with limited resources? Even with the highest resources country, I can say that we are facing some sort of resource exhaustion. So doing PET CT, as we call in Egypt, عمال على بطال, for every single case of ovarian cancer is nonsense. Of course, for endometrial cancer, it's totally non-logic. And for ovarian cancer, even with a stage 3 to 4, it is not necessary to do PET CT for every case. It delays the case. It sometimes goes over diagnosis. And I want this to go for all oncologists, because oncologists are very keen to do PET CTs for ovarian cancer and to make their decisions based on PET CT. And really, we don't need that. So that was our first part, that if we haven't done this PET CT, we would go for surgery, because those peritoneal stranding and omental stranding didn't appear in the CT, and we didn't need them really at that point. So again, PET CT, please reserve it for very, very specific indication. It is not routine for the cases, and you can follow up after that with PET CT, but not the primary diagnosis, and those are the ESGO guidelines.
And Basil, can I also add, again, I'm in agreement with you 100%. It is always beneficial to ask, why am I doing a specific test and what is the outcome that I want to achieve with that particular test? In this case, further evaluation of the disease extent would only have been beneficial to do a laparoscopic evaluation in some countries, in other countries, a direct laparotomic evaluation. But this, I think we will be moving on to that next.
Yeah.
Thank
So
you.
my second question was, why did you start from the start this case with neoadjuvant chemotherapy? What was the indication? And this is a thing again that I'm seeing very, very, very frequently in Egypt, in Bahrain, in North Africa, in every place. Once you have omental disease and peritoneal disease, you refer for neoadjuvant. And this is not the story. I want to hear some of our attendees, if any one of our attendees can say if he would advocate for.
Dr. Jean Abu Talib was asking, does she has an intrauterine mass?
Yes, she had an intrauterine mass release that they didn't biopsy before in the TB, and we are going back to it. Okay. But I want to hear the opinion if we have any oncologist side by or anyone.
هو انت قافل ان هم يتكلموا متهيألي مش عارف.
Q&A are there and they can raise their hands, I think, or write in
في
the
كيو
chat
اند
box.
اي في كيو اند اي.
There is a Q&A and
there is a Q&A. Yes, you can put your
yes,
questions in.
I see even Amani was congratulating Sarah.
Yes,
And
I just seen that. Thank you.
yes. So again, my dear onco-surgeons, gynecologists, and clinical and medical oncologists, omental diseases stage 3 and 4 is not indication to start neoadjuvant solo indication. It may be even after the trusted trial. Even after the trusted trial, it is not an indication to start once you have this. The trusted trial conclusion, if there is much morbidity. So what are the indications? Mohammed Khalaf is raising his hand. I'd like to hear Mohammed Khalaf. Please introduce yourself, Mohammed, and then you can ask or say whatever you want. Just unmute yourself and start. Unmute yourself, Mohammed, please.
ايوه حضرتك كده سامعني؟
Yes.
سامعين.
تمام.
ايوه طب يعني first the pathology of endometrial biopsy shown that mucinous adenocarcinoma. That's right, صح؟
Hello.
Yes, it was mucinous or endometrioid.
endometrioid mucinous ولا endometrioid
It was suggestive of either this or this, and they didn't reach a panel, a final panel, but mostly it was endometrioid because you have intrauterine mass as well. So I think it was endometrioid.
So يعني the best CT put us in obligatory situation where we decided neoadjuvant chemotherapy يعني somewhat resistant يعني.
What is the obligation? What is the obligation, Dr. Muhammad? يعني what was obligatory in البيت سي تي؟ يعني ايه اللي انت شفته في البيت سي تي؟ ايه اللي شفته في البيت سي تي خلاك تقول it's obligatory to start neoadjuvant؟
هو the omental cake and the omental deposit is not a contraindication for upfront surgery.
Yes.
انما maybe the surgeon has here the omental cake and there is some omental cake for continuous neoadjuvant chemotherapy. فيعني that put the patient in يعني wrong pathway from the start.
I can't say wrong. Okay, I can see now we agree that PET-CT was over diagnosis. Okay, but again, let us revise together. I totally agree with you. What are the indications of starting new adjuvant, even with the trusted trial? What are the indications of starting new adjuvant? Again, how we decide in the tumor board, we decide according to the disease burden and the location. This is number one, the disease burden and location. Number two, performance status. So our patient was 53 years old with performance status, excellent performance status, even after all those lines of chemotherapy. And surgical expertise is very important. Surgical expertise. That's why you should have a dedicated gynae oncologist, either from a gynecological background or an onco-surgeon who can do and is excellent in doing ovarian cancer surgery. So surgical expertise is important. So if you have some sort of surgeon who can't deal with the omental disease, peritoneal disease, yes, it's accepted to start a new adjuvant, but you can't be dealing with ovarian cancer cases. You must recruit some high volume case. Institutional philosophy and patient preference. So Sarah wants to say something. Please go, Sarah.
Bassel, thank you. I did not mean to interrupt. I just wanted to
No,
emphasize the point that you said is it's very important to know the criteria for neoadjuvant chemotherapy. And particularly, I wanted to emphasize the point that you mentioned about surgical expertise. So I absolutely agree that this needs to be something that needs to be evaluated. However, and you just said that it actually should not be a criteria. If there is no surgical expertise in that particular institution, which is absolutely fine, then there needs to be, however, a network with another institution where that expertise is available, and the patient needs to be transferred to that institution, or somebody needs to, so surgical expertise as such should not be a criteria for starting neoadjuvant chemotherapy unless there are other criteria that are an indication for that. So I agree with you. You just said it. Thank you.
Yeah. And so this gets us back to centralization of service, where we don't need in Egypt, for example, doing ovarian cancer or not surgery, just managing ovarian cancer in 40, 50 institutions, and even the private, and even in بعض يعني even not in the capitals وهكذا يعني أنا قصدي in very small villages and very small towns you don't ovarian cancer is very serious disease, a fatal disease that needs to be centralized, to have fewer centers discussing all the cases in the tumor board, referring to the يعني centers of excellence. Even is being done in Germany now. Like you must have at least 30 cases per year to do ovarian cancer surgery. Before, every center can do ovarian cancer surgery, but now they are putting some criteria. You should have at least 30 or 40 ovarian cancer cases per year to be allowed to do ovarian cancer surgery. Even in Bahrain, a very small country, no one is allowed to deal with ovarian cancer surgery except with the National Cancer Center, okay, and except after a tumor board. So saying that I don't have the capacities, you can refer to the nearest part. عندك NCI، مستشفى الشرقي في اسكندرية، جامعة المنصورة، في أسيوط، وحدة الأورام في النساء أو في جراحة الأورام. أنا قصدي you have centers، بس ما ينفعش القرارات تتاخد in every single cancer center small يعني.
Basil, I can maybe ask a provocative questions with regards to that. Yani, you're absolutely right. Hatta in Germany, there is no official centralization as of yet. There is in the UK, in Germany, and in Italy. It is not centralized, so centers can operate. You don't have to send to one, but we're working towards centralization. I wonder about the economic implications of
Yes.
patient referrals. What is your opinion? Because I think we don't like to talk about it, but I think this is some of the reasons why even in Germany, some patients may not get referred straight away, because there is obviously economic implications to referring a patient and losing a patient to another institution.
Yes, of
I'm
course.
asking very provocatively
Yes.
on purpose.
Very clearly, some would like to manage in the private, which put a great financial burden on the patient. So not referring the patient is much more financially toxic to the patient rather than referring the patient. So some will say the patient can go like this, but so we have two problems: either doing it in the private part, okay. And so I'm not against the private, but you have at least to decide and discuss at the tumor board. It can't be a single doctor sitting in a clinic and then taking a decision alone, of course, of doing something, especially if he is doing all the oncology or all the surgery. He is not expert in that part. So you can't go, I'm an oncologist who I'm doing lung, sarcoma, breast, gynae, and then taking decision, I'm going to start new adjuvant, no tumor boards, nothing. So this is not accepted. So we have the private part, or doing it in small hospitals or small centers. So you have like now one small town, you have a cancer center and you have the university hospital. So again, the Ministry of Health hospital wants to work, and then another hospital wants to work, and then like a secondary referral hospital wants to work. And this is not things should be doing like this. But referring in Egypt I think is very easy to refer to one of the university or the large Ministry of Health cancer centers. In the Ministry of Health, we have many cancer centers in Dumyat, in Kafr al-Sheikh. There are many cancer centers in Egypt. The same criteria in Saudi Arabia. In Bahrain, we have the main cancer center. So referral, I don't think it has financial implication on the state. It may have financial implication on the doctor only.
That is what I meant, yes.
Yes, not on the patient, not on the state, not on the hospital, but only the doctor. So that's why I don't like playing with ovarian cancer. Okay. So again, if we go to the criteria that I want to be clear. We have criteria which are in red. We have seen in many slides before, in many presentations we have done, and all the experts have done. What are the criteria of non-resectability? Multiple or extensive pleural or pulmonary metastasis, which wasn't our case, mediastinal or retrocrural lymph nodes, multiple or extensive hepatic parenchymal metastasis, and again, this is very important, the parenchymal metastasis, not the subcapsular, because you can easily strip the liver capsules, so you must have a good MDT, a good radiologist, and ask him if those liver lesions are subcapsular or parenchymal. So if they are multiple extensive parenchymal, yes, this is non-resectable. Or central small bowel mesentery, multiple extensive serosal implants, gastric implants that will need total gastrectomy or total colectomy, celiac or hepatic gastric artery encasement, or bone mets, which is extremely rare in ovarian cancer. Those are things that are usually non-resectable. Otherwise, you can resect the whole omentum easily, even with a very large omental cake easily. All the peritoneum can be resected. There is nothing against resectability in the pelvis, so you can never say. So those again are the red flags: multiple parenchymal lung mets, multiple parenchymal liver mets, and the diffuse deep infiltration of small bowel mesentery, diffuse carcinomatosis of the small bowels that necessitate excising most of the small bowel, diffuse involvement and deep infiltration of stomach, duodenum, pancreas, 2 colonic segments, you will need total colectomy, stoma for the patient, hepatic hilum infiltration, brain bone mets, which are extremely rare, celiac trunk, hepatic artery, and left gastric artery encasement. Otherwise, everything is resectable, okay? So what I want to say that we should do this. And again, I want to go to say optimal debulking shouldn't be some subjective decision. It should be objective. We should agree together. So either we do a peritoneal cancer index, which is done by CT, or doing a Fagotti scoring by laparoscopy, as Sarah said, you go by laparoscopy. And then what I do for my fellows now in Bahrain, we have many cases of ovarian cancer. I say I'm going to put the camera inside, okay? And then you go and do indexing, say what's the Fagotti score of this case. Is it 2? Is it 4? Is it 6? Okay, something like that. And then you tell us according to this. You shouldn't leave it for the خيال القارئ. يعني sometimes really this is, يعني don't take it harsh, but sometimes you start a case at 1 or 2 p.m. and the doctor wants to go, he is very exhausted, and so he say, it's advanced, I have peritoneal nodules, I have this advanced, no, it is non-debulkable, I'm going to have a biopsy and refer to neoadjuvant. So I ask him, what is the PCI or what is the Fagotti scoring? And then he said, oh, Fagotti, it's like 2 to 3. So I don't think this is an unresectable disease. So we should agree to make it objective with some scoring, whatever the scoring system you want to do, the Aletti scoring, the MSK scoring of the Muslim catering, the Fagotti scoring, the PCI scoring of Sugar Baker, whatever, but we should agree not to leave it just for the surgeon or to different expertise to say, is it resectable or not? Okay? So from those criteria, the PCI was low. Okay, if we go to the PCI, it was very low. And if we go to the Fagotti scoring, it was low. And there is nothing which is contraindication to surgery. So the decision from the start, I can't say it is wrong decision, but I can say it is questionable and deeply questionable why you start a neoadjuvant in such a case. Okay, even ascites, sometimes you don't like to go with weight patient, very weight patient, if it is a moderate to marked ascites, but it regressed after that with the chemotherapy. So I didn't have any contraindication for surgery. Okay, those are the ESGO guidelines, the new guidelines. And so again, large volume ascites, you can do site reduction. Serous high grade, serous or serous low grade, you do site reduction. Okay, only the red flags if you are going to leave bulky disease more than 1 centimeter, again according to that. Okay, so that is the ESGO guidelines, and you will find those figures very clear in that. Okay, so she started chemotherapy, and again the question, should we have 3 cycles or 6 cycles of neoadjuvant chemotherapy? I'd like to hear the attendees and or Khalid or Sarah. What do you think, 3 cycles or 6 cycles?
3 cycles first.
Yeah, so we give 3 cycles and then we assess by CT or whatever, okay? Again, there was the chrono trial. It was very promising. I heard from Christina Fotopoulou that 6 cycles will be equal to 3 cycles like breast cancer, but it was published in ASCO just last month, and it was negative trial. So again, 6 cycles add nothing for the patient, just delaying the surgery, and we don't have clues for the delayed debulking surgery. But again, the still standard of care, 3 cycles of chemotherapy, and even after the chrono trial now, which was published in ASCO, again, the standard of care is 3 to 4 cycles, and then you assess the patient. So again,
Marco is asking to يعني خلي الفول سكرين يا دكتور باسل
حاضر
الفول سكرين
like this. So again, that case was considered platinum resistant, okay, and that there is no response. So again, I'd ask Sarah and Khalid from your expertise, and Hisham, of course, if he's here, and anyone, what's your expectations for response in a very large ovarian mass? How do you expect the response to be? It's a 20 centimeter mass. So how do you expect it to be after 3 cycles of chemotherapy?
Let me just check if somebody from the audience, please. Dr. Khalid, I think you were saying something. Please go ahead.
I was going to say that if a mass is that large, I would not expect too much regression for that size. And even a mass of that large, I would not expect a very heavy peritoneal disease with from the start. Usually the very large masses, like the high-grade serous carcinoma, not come with a very large mass like this. Endometrioid don't come with a very large mass like this. Mostly the mucinous types who may come, or the borderline tumors who come with a very large mass like this. And I don't think after 3 cycles you will have from a mass 20 centimeter that will be regress to 10 or 5 centimeters.
Great. This is very important for the experts as Khalid in gynecology. Those large masses seldom are inoperable. Okay, those very large masses are seldom inoperable. Yes, sometimes you can have a heavy peritoneal disease, but again, you are not expecting that this 20 centimeter mass will be 5 centimeter or 6 centimeter, even with complete tumor necrosis. So chemotherapy can cause complete tumor necrosis, but still there will be inside the mass would be a very large cyst with necrotic tumor, nothing, خلاص, it is not active anymore. In PET-CT, it will not be active, and it will be all this necrotic yellowish tissue inside the ovarian mass, but it will remain 20 centimeter, okay? Because usually you don't give neoadjuvant for those very large ovarian masses. Even they will be compressing the bowel and causing respiratory distress, causing some sort of dyspepsia, and the patient will not be able to eat well, and she will have some nutritional problems. So we don't expect the response. And how we measure the response, we have what we call the RECIST criteria. Again, our radiologists should be aware of that. And we define stable disease, okay, disappearance of all lesions. So we have a target lesion and the non-target lesions. The target lesion would never be the large mass, okay? And you have the target lesion and non-target lesion, and you can say if it is all disappeared, this is a complete clinical response. If there is more than 30% decrease, okay, or no new lesions, this is a progressive disease, and or you have a regressive disease with more than 20%. Okay, so we have a stable disease, progressive disease, or regressive disease, and progressive disease must increase more than 30%, and stable disease and the response for that. So we should define response according again to criteria, مش برضه بنتركها الخيال القارئ. So for this patient, the ascites was totally regressed, the peritoneal disease and the omental disease were more or less stable, they are very small, and the ascites totally disappeared. And so this is how we define the response, not based on the tumor marker as well. Okay, so that was the response. So you don't wait just response in such a patient. Okay, so we ask it to do now interval debulking surgery. Is it called interval debulking? No, it is not called interval. We call it delayed debulking surgery because she had 6 cycles of chemotherapy. So I asked them in the tumor board, please, I don't have any contraindication for surgery. She is not going to start palliative. Let her have her the chance for doing a surgery. And so we go inside, and that was the view. You see the view. This is a very large mass with the tumor necrosis inside, and you can see a very clear abdomen, no peritoneal disease, no omental disease, a very straightforward, easy case. That is before operation. This is not after operation. This is just after removal of the mass. Okay, I didn't do peritonectomy. I didn't do any. Just doing omental cake. So
I think there is no omental cakes visible.
Yes. No. We removed the omentum already, and it was like a fellow's case. It just you put the clamp behind it. It wasn't a surgeon case, and so we did a total abdominal hysterectomy, salpingioophorectomy, and bulky lymph node removal. Okay. and the omentum grossly was normal, the peritoneal was normal, there was no just some large lymph nodes. Okay, we had aortic bleeding, and hemostasis was done with BDS3. And if you ask me why you did lymphadenectomy, because she was endometrioid grade 2, endometrioid grade 2, so it is equivocal. So you, of course, we don't have place for lymphadenectomy in delayed debulking. We remove only the bulky lymph nodes, but because this one, it was grade 2 to grade 3, so we did that, and it was a very easy operation. Okay, and that is the final total optimal site reduction. So this patient was about to be deprived from her chances for cure, and she was about to go for palliative disease with this large mass inside, preventing her. She's very young, very slim, very nice lady. The pathology turned out to be bilateral ovarian endometrioid adenocarcinoma, okay, FIGO grade 2, and the uterus had the same endometrioid carcinoma as well. The para-aortic lymph node were negative, the left pelvic lymph nodes were negative, and the omentum peritoneum was all benign fibrofat tissue negative for metastasis. So it was bilateral ovarian endometrioid adenocarcinoma grade 2. And so we sent for observation, and her follow-up imaging study was just last month, and it was totally normal, nothing in here after the operation by 4 months. It was total clear, no nothing at all, no local recurrence, no lymphadenopathy, and CT chest, nothing in the chest, and everything was stable. So this patient was shifted from going to palliative care to a near cure. We are speaking about cure now in such a patient, just by taking it step by step, thinking thoroughly. Okay, that was her last CT, totally free disease, nothing in the CT. And so our key points to remember: upfront surgery versus neoadjuvant should be an MDT decision. The main first question should be addressed to qualified surgeon. So in the MDT, you sit together, ask the surgeon first, can you achieve optimal resectability and with expected morbidity and recovery? Again, trust is speaking about the morbidity and mortality. Omental and peritoneal metastases are not enough indications for starting neoadjuvant chemotherapy, except it is a very high PCI, either radiologically or after lab assessment. PET-CT is not standard of care in primary assessment of ovarian cancer. Response assessment should follow agreed criteria. It is how we are following response. And so that is the idea of our new series, Decisions Before Incisions. It is not important how good you are at surgery. That surgery was very easy. Anyone can do the surgery, but it's about the decision, how to take the patient, which patient to take for theater or which patient not to take for theater. That was our case, and I am waiting for your comments, for your questions, for your inputs, and anything from you. Thank you.
Dr. Aman is saying great learning case. Also, it would be uncommon to have advanced disease at presentation of endometrioid or mucinous ovarian cancer.
Yes, yes. Every single pathology is different. You should know every single pathology, and every case is different from the other. Sarah, what's your comment?
Thank you very much, Dr. Basel. This case is a perfect example to see that there are criteria. So we don't move with the treatment of a patient with what we feel is correct, but there is actually enough evidence to guide our treatment decisions. And you beautifully also said, there is the science and there is the art. So we have the Fagotti score. We have criteria for resectability. And then within that, we may have one or two cases that are more particular that we then need to deviate from certain guidelines and certain criteria. But actually, there is evidence and there is guidelines for the treatment of patients. I think the way the case went, the points that you mentioned were absolutely correct. These were the checkpoint where treatment should have gone in one particular way and however went in the other way. So what would be interesting to hear from maybe also our attendees, also from yourselves, Khalid and Basel, is this something that you see very often? And is there anything else that you would have done differently in this case? Because I think the way the case, the way this was picked up at the National Tumor Board is great. It was picked up with that. And, how many cases are maybe not being picked up? And it emphasizes again the importance of a network of mutual support, really, and education.
If I speak about Egypt, there are many. Our problem is here, the main problem is that till now we are fighting about the definition of subspecialty. We don't really have a main subspecialty in many parts of Egypt. Okay. So the case, if she mainly if she is went to a medical oncologist at first, and maybe the medical oncologist is not even subspecialized in gynecology, he will give her chemotherapy till the end. He gave chemo, and it's very common to see 6 cycles of chemotherapy. Just recently, I've operated a case, a very nice case, who had a very good response after 3 cycles, and she received another 3 cycles of chemotherapy. I didn't know why. And this is very common to see here, unfortunately, in Egypt, because until now we don't have well-performed subspecialties, and even in some regions, the subspecialties are only on paper. Yeah, you have a place, maybe you have a unit, but are the people really specialized to do that thing? That's the main problem in Egypt.
Yes, and that, I think a very important part is centralization again, because simply, Sarah, I can tell you that most people, for example, who are attending today, they all know what we are saying, and they will not do what we are trying to make people. Others don't care about learning, don't care about attending anything. They are doing, as I say, if they are a gynecologist, if he is a gynecologist, or she is doing obstetrics, IVF, gynecology, aesthetic gynecology now, and blah blah blah. If he's a surgeon, he's doing thyroid, breast, colon, sarcoma, and then ovary, by the way. And so he doesn't have the time to attend such series. He doesn't know, and he doesn't change his practice. And so it depends on the patient luck. Where is the patient going? Is she going to a good center? Is she going to a dedicated doctor? So but everyone is allowed to do anything, and this is something that must stop really. So that case, why she was picked up, because she is in Bahrain. This was very, very frequent in Bahrain, but few months ago or 1 year ago, there was a circular: no one to deal with any cancer case or suspected cancer case except after discussions in the National Tumor Board. So once she discussed the tumor board, she was picked, and alhamdulillah, she was saved. Okay, so we need this in every country, every good tumor boards and decisions from the authorities that cancer is not a toy, and it should be discussed in the tumor board. I think Hisham wants to say something.
Please.
Unmute yourself, Hisham, please.
Hello.
Hello, Hisham.
Hello. I think we have a good case, a good example for what we see every day. And I think in the near future, maybe in Egypt, the situation will be the same and will not change much. So, unfortunately, actually. And I think anyone in Egypt will know what I am saying. So, discussing such cases, I think we learn from each other how to get a good clinical decision for such, I think, peculiar cases that we see every day but are not written in the books. What we are going to do for a case that received neoadjuvant chemotherapy for 6 cycles. Sometimes we see even more than more than 6 cycles, and even having different lines of treatment, and it is actually resectable. What we are going to do when we see cases that is of endometrial carcinoma that it is incompletely staged, and what we are going to face, and what we are going to see cases of cancer cervix that did subtotal hysterectomy or total hysterectomy without radicality, and so on. To sum up, we have to move into two pathways. The one pathway which will give a good service, as Basel said, to have centralization, a good subspecialty in gynecology, and the other way that may be more realistic in the real world that we are seeing every day is that how to put a clinical pathway and good decision making for the special situations that we are seeing every day for cases that is maybe mismanaged at the initially. And thank you.
And thank you, Sham. And education, like what PARSGO is doing now through this series. We will never stop education. At least we have 10 to 15 doctors who are learning, and so this 10 to 15 will save at least 1,000 patients.
Yes, fortunately, we have Basel Refky with us. That is pioneering gynecology. I think that our specialty is having good luck than the other specialties, because this is in every specialty actually, not only in gynecology.
Mazboot, Dr. Hisham, I also agree. There is, a medical oncology, whether it's in Egypt or in Germany, will want to give chemotherapy. A radiologist a radiotherapist will want to do radiotherapy. A surgeon will want to operate. So we all do have this tendency to think within our own silos, but then we have a system that is in place and an infrastructure that's in place that kind of guides us to work together. And so that's what we do. And when that system or that infrastructure is not there, is not present, then this is what happens as we see. And things will not change overnight. I do believe that things will change. It might be small changes over time, but as you all said, education, awareness, talking to politicians, talking to healthcare authorities. So we're talking about various levels of making people aware of what needs to be done. I also think it's very interesting, Dr. Hisham, what you said about the two parallel pathways. So obviously educating on the correct management, but in the meantime, you have cases that are mismanaged. In Egypt or in Germany or in Italy, this happens, probably maybe in Egypt, as you said, more frequently, but you will always have some cases that may be mismanaged and that you have to then manage. These will be cases that need to be discussed on an individual basis and will obviously be outside of the guidelines, or where guidelines need to be adapted.
Thank you,
Any
Sarah,
other
so much.
comments? Yeah, please, Basel.
Yeah, just I'd like to ask you if you liked the idea, because I think the idea was very unclear of the decisions before incisions. Now it's clear, I think, and that's how we are going to present the cases every month. Only one case, going in details and going back to the evidence to discuss it from real life. All the cases in decisions before incisions will be cases from real life with them. And so I encourage every one of you, of course, of PARSGO steering committee and PARSGO members of EGOS, and even of the participants, if anyone has an interesting case that can be not a rare case, not something which is very weird like what we discuss in the PARSGO tumor board, but a straightforward educational case, please don't hesitate to discuss it with us, and then you can be the following presenter. I have like 1 or 2 cases for the next 2 months, and then Sarah have, I think, a case in September or something like that. And then any one of you can present the cases. That is the idea of decisions, or this is the spirit of decisions before incisions.
Thank you, Basel.
You
Please, Dr. Hisham.
had cases, how to send them.
To Basel.
We will find some pathway, but you are the last one to ask this question because you can send it for me. But we will put.
Okay, I'll send it to you. Okay,
after
that will be very easy.
Yes, after 2 or 3 months, when everything is clear and everyone knows, I think we should put a frame and pathway, a specific pathway. But for you, Sham, you can of course just call me, and I want to put this case. You just order. You don't ask yet.
Absolutely.
Yeah.
We also have a comment from Dr. Hajar. Thankful for informative, astonishing lecture, emphasizing on training and awareness. Changes do take time, but over time it works by people who care and who are resilient. And I think we all are caring and resilient here. So I want to ul mabruk to everybody for being here, for carrying the spirit of EGOS and of PARSGO, and for really turning up when it matters most. Amjad.
Yeah, thank you. I'd like to ask you to circulate this case. We are going to post the recording as usual on the EGOS page, and so you can, and PARSGO, of course, website.
Yes.
So you can circulate this case to your colleagues, to your oncologist friends, to discuss it together. I think this would be a good something for learning. Yeah.
And you see also it is a safe environment, Yani. We're discussing amongst colleagues. We're really looking, how can we have done it better? How can we make it better? How can we prevent it happening to other patients? And so this is, like Basel said, it's about de-escalating and looking at what can be improved.
Yeah.
So please feel free. Okay.
Okay.
Any more questions, comments? Khalid, please.
For me, not.
Yes.
Okay. Then I think, Basel, I will leave the closing words to you, as this is our very first session and you have very beautifully presented this case.
Thank you, Sarah, for giving us the opportunity to do it through PARSGO. Really, it's an honor to do it through PARSGO. And thank you, Khaled, for being dedicated for that. You are resilient and you are doing this. And thank you, everyone of the attendees. I hope to propagate this series more and more among your colleagues, especially of other disciplines rather than surgeons. So I'd like to ask everyone for you to circulate the registration link. And I promise you, we are having many, many interesting cases from real life in the next few months. And again, we are encouraging everyone to send us to present his case if he has something that can people educate. When I was thinking about this series, decisions before incisions or touching the ground, we want to touch the ground, okay? Yes, so thank you. And I have to go now to Tunisia to present their next day.
Have a great journey, Basel. Thank you, everybody.
Thank
Shukran.
you. Thank you. Bye.
Thank you all. Bye.